Welcome back, everybody. I hope you've all had an opportunity to have a drink and at least move around away from your screens and your desks. So again, we're working Lucy hard this morning. Lucy's going to co-chair this next session, which is the oral presentations from the submitted abstracts to this conference. Again, like the previous session, there are longer 10-minute presentations available on our website. Hopefully some of you have had an opportunity to watch them before now, but maybe for those of you that haven't, if there's something that particularly interests you in the short presentations, then you will have an opportunity afterwards to look again at the longer presentations. It's a real pleasure to be able to be introducing some practitioners, some clinicians, and some academics as part of this session. I am going to be harsh, folks. I'm going to switch my camera off while you're talking. If I reappear, then it's time to stop talking to make sure that we stay to time and give everybody the opportunity. Again, we're going to start and go through all the presentations and then have the questions and answer session afterwards. So please do start putting questions into the question and answer function as we go along. So first up we have, I'm really pleased to introduce Archana Soman, who's a consultant paediatrician at Sheffield Children's Hospital and at Bluebellwood Children's Hospice. And Archana is going to be talking about learning from bereaved families to improve children's palliative care, a qualitative study.
Hello, everyone, and thank you very much for this opportunity. This was a study that I conducted in east of England, so it's not a local study, and it was this is a qualitative part of a mixed method study and is about interviews with parents of 9 children who had died of life-limiting conditions in the preceding 5 years. This was a very rich study in the amount of themes that came up and the number of powerful quotations from families. And I have listed a few in my main talk, which I would really encourage you all to read because they are much more powerful than whatever I can say. The large number of themes that evolved were grouped into sub-themes, and the sub-themes were then collapsed into major themes, and the major themes were collapsed into 3 superordinate themes. And the most salient, the most frequent, and the most powerful was themes under communication, which came out as a powerful and essential tool to be used with care. The major themes under the superordinate theme of communication was 1, sharing and understanding of facts. Parents felt that we usually beat around the bush about prognoses, trying to be kind, but in the process being even crueler. We lacked clarity in our information sharing. We failed to respect parents' expertise about their children, and we also failed to communicate to each other, needing parents to repeat their stories to everyone. Very powerful was their experience of the affective aspects of our communication. There were instances where we lacked humaneness, empathy, and compassion, basic courtesy and respect, sensitivity in the words we used, how the atmosphere we have discussions in can be daunting, etc. There were also glaring lacks of advanced care planning or resuscitation planning and parallel planning for unexpected improvement. The themes under the impact of life-limiting conditions beyond the clinics, these are the impacts that we don't see as clinicians. I grouped them under 2 major themes. One was a child's one was the emotional and behavioral responses that the condition in the child elicited in the parents and the wider family members. They talked about denial, they talked about hope, they talked about how it changed their personalities, but also they talked about the practical challenges that they faced, how they had to bargain for services in health and in education, and how they had to juggle a whole lot of other life issues outside of the child's care, along with the medical complexities. The themes also could be collapsed under the major theme called priorities, where obviously the main priority was child's comfort. Symptom control was top of the list. Also, the choice of place of care, the teams that provided care, the choice of hospice care, etc., were important. In practical support, parents valued access to 24/7 resources, which would provide seamless palliative care. They valued advice and guidance on practical matters, particularly surrounding death. And most families also valued the hospice support that they received. This study obviously had a number of limitations, the number of the small sample size being the most important, but it also had recall bias, recruitment bias, because the families who chose to participate were, I think, mostly people who had bad experiences. There was obviously my own bias must have crept in, but there was also socio-cultural homogeneity. They were all white middle-class parents, most of them, and diagnostic heterogeneity when it should have been the other way around. However, none of the families needed any, the interviews did not cause distress needing intervention in any of the families. And they felt that talking helped in dealing with their issues. The conclusion to me is that I saw a comment in the question and answer section from Dr. Miller, who said pediatric palliative care is the last bastion of pediatrics. I think pediatric palliative care seems to be the last bastion of humanity in medicine. And we need to drive the message of improving sensitive communication and to the importance of being empathic towards our families when we have these extremely difficult situations. I couldn't think of sadder situations for families than life-limiting conditions in their children, and we need to be human with them.
Thank you, Archana. That's brilliant. Thank you very much. So can we move now on to Mandy Brimble? Mandy is a senior lecturer and doctoral student at Cardiff University, and Mandy's going to talk to us about how do children's nurses working in hospices manage emotional labour and professional integrity in long-term relationships with parents.
Thank you very much. So the data collected for this study was collected from 6 nurses who were working in 5 different hospices in England. They'd worked in the hospice for 4 years or more, and the families that they talked about they'd known for 3 years or more, and they were asked to focus on short break and daycare interactions rather than end of life situations, and the data was collected using audio diaries and then followed up with a telephone interview. So what I found was that the participants were really skilled in managing the relational aspect and the emotional aspects of their role, and I've labelled the themes here accordingly, and the sub-themes. So the purposeful positioning, very much about that psychological space that you have to make between yourself and families, and also managing empathy and emotional self-regulation. Now that theme really could probably be applied across the board in lots of situations, but the things that were really pertinent to the hospice environment were the balancing personability with professionalism, and the I'm a friendly professional, not their friend, and managed self-disclosure. There was a sense that people, because of the environment, felt not pressured really, but almost obliged to take on a different professional persona than they would elsewhere. And then also particularly relevant to hospices was the coping with and counterbalancing emotional labour. And these practitioners had all worked for some other environment for at least a year before they worked at the hospice. And these were things that they particularly highlighted as being particular to the hospice, that really helped them cope with the emotional demands of their role. As you can see there, the job satisfaction that they got, positivity and fun around memory making activities and everything that goes with working at the hospice. And also the extraordinary peer support. So lots of what they were telling me was indicative of emotional intelligence traits, self-awareness, self-regulation, social skills, empathy, and intrinsic motivation. But the really interesting thing was that there was almost a circular relationship with the coping and counterbalancing emotional labour features, because these seem to not only require some sort of emotional intelligence, but it also helped the participants to build emotional intelligence so that they were better able then to cope with the issues that they raised in the purposeful positioning theme. So kind of moving this work forward, my recommendations would be that maybe emotional intelligence assessment and training could be part of recruitment, staff development and so on in children's hospices and in other areas. And in terms of educating children's nurses, both pre and post registration, awareness could be raised of emotional intelligence traits, because actually some research shows that people don't, or practitioners don't even know really what this is, and those skills could be developed both in students and in practitioners that are already working in the field. And that's it. Thank you very much for your attention.
Thank you, Mandy. Can we move on next to George Peat? Now, George is going to talk to us about an interpretive phenomenological analysis of the role of social media in the lives of young men with Duchenne muscular dystrophy. Now, it says on the programme that George is a PhD student at the University of Leeds. If Twitter's to be believed, then I think you're now successfully past your PhD, George. And I remember when you came to our last conference 2 years ago presenting your initial plan, so it's lovely to see you back, and congratulations on passing your PhD.
Many thanks, Lorna. Thank you. So when we think of the term social media, sites and apps such as Facebook, Instagram and Twitter may spring to mind. For others, the term may be synonymous with YouTube, Snapchat, blogging or even video gaming. Its meaning to us is representative of our individual situated perspectives, or our own unique life worlds that shape and provide meaning to the phenomena we encounter in our everyday world. My study was interested in the situated perspectives of 8 young men with Duchenne muscular dystrophy and the role of social media in their everyday lives. Using an interpretive phenomenological approach that recognises the search for meaning as an interpretive exercise shared between researcher and participants, I engaged in sequential, in-depth interviewing using techniques such as video gaming during interview to create a space where participants could explore and make sense of the unique meaning of social media in their everyday lives. The result of this interpretive exercise was an insight into what I termed the essential components of the lived experience of social media to the 8 young men I interviewed, illustrated by the diagram on my slide. Each exists as a result of an interplay between the offline and online life worlds of participants. For example, participants spoke of escaping their offline life world through video gaming. Escapism was experienced as a shutting out, or a space to forget, or to engage in activity otherwise unavailable offline, such as driving, horse riding, and activities such as shaving and grooming. Likewise, participants spoke of the ability to express control over aspects of the self they reveal to others online, in order to form a sense of self in terms of how they wish to be viewed, something they often struggle to do offline, and they sort of draw on experiences such as bullying and things like pointing, staring, and invasive gestures. Similarly, the benefits of closed groups on Facebook associated with DMD were expressed, such as the ability to express autonomy to source answers to queries related to DMD, or indeed provide answers to those queries from other people. Underpinning the meaning of social media was this concept of accessibility, the idea of being able to reach or enter somewhere. Participants described offline experiences that were often included around the notion of difficulties with educational and social opportunity. For these participants, social media offered an alternative life world to enter and discover. Nevertheless, participants frequently encountered accessibility challenges when online as well, such as difficulty in pressing certain buttons on controllers, for instance. Notably, for participants who described rich and meaningful offline experiences, social media appeared to carry less meaning. It is important that the utility of social media to young men with DMD and indeed other life-limiting conditions are recognised so that the population can be signposted and supported to use it where appropriate. This is not negating the need to provide young men with DMD and other life-limiting conditions with access to other meaningful offline life experiences. However, where young men with DMD can be supported to live fulfilling and meaningful lives both in and outside of social media, my research found they were able to shape positive identities. Thank you.
Thanks, George. So next we have Wahida Kent, a lecturer at the University of South Wales. And Wahida's going to talk to us about her study on Black and minority ethnic parents' experiences of caring for a child with a life-limiting condition.
Hello, today I'm going to talk about my PhD research. The background to this research was driven by the fact that there's a dearth of research with the parent carers of Black and minority ethnic children with life-limiting conditions. This was highlighted further by Professor Richard Harding this morning. Little is known about their experiences and their access to and take up of formal and informal support and challenges they may face. So the aim of this study was to bridge this gap by interviewing 20 parent carers in England and Wales and 10 professionals working in hospice, health, education and social care. The aim was to explore whether there is ethnic variance in terms of the needs of this group of families and the way that they experience caring for a life-limited child. The methodology adopted was qualitative in-depth interviews with parent carers as well as professionals. It was to explore how ethnicity, race and religion impact on this group. The qualitative research is further supported with a quantitative element which involved analysis of wave 5 of the Millennium Cohort Study, which provides an excellent comparison between Black and minority ethnic children, white children, Black and minority ethnic children with long-standing illnesses and Black children without long-standing illnesses. So it was quite a useful process to go through, which highlighted the lack of quantitative data in relation to ethnicity and children with life-limiting conditions. So some of the results that I can talk about today are that essentially Black and minority ethnic parent carers of children with life-limiting conditions face some of the same challenges that white parent carers do. These may be further compounded by issues such as immigration status, language, literacy issues, so that they could be some of the additional barriers that the families face. However, the BME parent carers I spoke to spoke of some of the themes that have already been spoken about by people earlier in their research: the negative impact on their mental health and physical health and well-being, impact on siblings, trying to maintain a sense of normality for the family. The findings actually challenge some of the academic discourse and anecdotal feedback from professionals regarding access to and the greater availability of informal support through friends, family and religious institutions. So one of the drivers for this research was practitioners saying that they were not engaging with BME families and trying to explore what the barriers could be, and often the greater availability of informal support for BME families was cited by practitioners as being a barrier. Religion and culture were another rationale provided for forming a barrier to accessing formal services. However, through my research, I was able to establish that no family felt that religion or culture was a barrier. And although there was availability of informal support, because of the immigration patterns, many families were dispersed around the globe. So the support that they received from family was tended to be emotional support rather than practical support. So a lot of findings challenged what previously held beliefs were. And it's like Dr. Anne-Marie Charles said this morning, we think we know, but we don't know. We need to listen. So even after having worked for 13 years with BME parent carers of children with life-limiting illnesses, my knowledge, my beliefs were challenged. A lot of the findings definitely challenged previously held academic beliefs. So hospice support was valued by those who took up the service. Family and social networks, again, were dispersed and very helpful, but only in terms of emotional support. Professionals wanted training to support their confidence in terms of assessing religious and cultural needs of BME families. Thank you.
Thank you, Rita. So we're now going to move on to a presentation by Dr. Susie Lapwood.
Thank you. So I'm talking about the creation of the Oxford Centre for Evidence-Based Medicine COVID-19 Palliative Care Group. What can we learn? And could this be a silver lining from this COVID-dominated year? This was a real highlight of the past year for me. I was just stunned that through this group, we produced so much work, so many reviews so quickly to make a difference to care on the front line in COVID. My full presentation covers the creation of the group, the rapid reviews of evidence that we produced, and there's some links at the bottom of the slide there, and most importantly, some suggestions about transferable principles, which are the focus of these few minutes now. So I need to tell you a little about the group. The Oxford Centre for Evidence-Based Medicine set up a COVID-19 evidence service very early on in the pandemic. They realised a need for palliative and end-of-life care input. And so just 3 days into lockdown 1, Prof Trish Greenhouse asked me if I'd help facilitate that. So within just a fortnight, our new palliative care core group had our first meeting with some fabulous clinicians and researchers from a range of settings and interests, including PPI input, health economist, and information scientist, all of us volunteers. And we gleaned a number of questions from the front line to start us off, seeking rapid evidence review, mostly from the amazing Hospice UK COVID Echo meetings, which had over 100 hospice and palliative care leaders meeting regularly over Zoom. We'd already prioritised 4 of those questions, and we set about then commissioning reviews, having checked nobody else was working on those topics. We commissioned a separate expert review team for each topic, with representation from one of our core group on each to ensure consistency in communication. We then provided informal peer review of the completed review, posted it on the centre website, and were able to feed back verbally to the next COVID Echo as well, which was a brilliant direct translation opportunity to translate findings into clinical care. Just a month after that initial meeting, we had the first 2 completed reviews posted on the website, one about oxygen for breathlessness and one about non-pharmacological management of delirium. 3 more reviews followed over the next 2 months. 2 more are in the pipeline. So what were the magic ingredients that made all this work? I think there are 3 broad factors, and I've put those on the right of the slide. The attitudes people brought, the function, which was about our structure and process, and some resources, not much, but just enough to oil the wheels. So moving to the left slide, I've highlighted 4 aspects in more detail. The structure and process that I've already described. But thirdly, and a real highlight, was our live learning loop. So we had a standing invitation to present back to the Hospice UK COVID Echo meetings, which had provided many of the review questions in the first place. So we could actually deliver answers to the front line for the questions they'd asked, which was brilliant. And then lastly, we had inbuilt vehicles for collaboration, the wonderful Zoom and Google Docs. And then for dissemination, which was attractive to the review teams, we could offer them the CEBM COVID-19 webpage and the COVID Echo to get their answers out to the front line. There's no time to tell you now about the individual reviews, but you can find them via the links, and of course they're on the full presentation. But I particularly recommend the paper on the transmucosal route for drug administration, because it's so relevant for children's palliative care, and I wish I'd had it available earlier in my own clinical practice. I've learnt loads. I hope you can too. Thank you.
Thanks, Susie. So the last speaker in this session is Dr. Nikki Harris, who is a palliative care consultant and PhD student at the University of West England. And Nikki is going to talk to us about harnessing modern communications technology to deliver person-centred care for children with life-limited conditions. What works, for whom, under what circumstances, and why? Thanks.
Thanks, Lorna. So basically, I'm going to tell you about my PhD, the title of which Lorna has just shared with you. The intervention that I'm looking at is My Quality. It's a website that combines individualized outcome measurement with symptom tracking and data sharing capabilities. And the aim of this approach is to highlight the concerns of from the family and child and family's perspective, to harness their expertise in their own care or the care of their children, and to improve communications and collaborative working, all of which are key components of a person-centered model of care. And it was so good to hear Richard Harding talk about the importance of that in the quality of what we do. So over the past 2 years, I've been approaching teams working with children with life-limiting conditions in my area to introduce them to the website, and then I asked them to identify families on their caseloads who might like to use it. And through pre and post interviews about their experiences and observation of website use, that helped me to understand what worked or didn't work, for whom, under what circumstances, and why. So in total, I had 15 families and 10 teams consisting of 47 professionals who took part, and that generated 1,800 days of My Quality use by the families and 38 interviews in total. From those, the families identified 4 main ways in which this approach really helped them at home. Firstly, by giving them more efficient use of time that facilitated normal family life. Secondly, they were recording real life, the good and the bad stuff, which was really valuable to them. They were telling their story and getting their viewpoint across, and that the insights that they gained from using the website improved the knowledge and understanding that they have about their child's health. This supported them to bring a clearer description of their priorities for care into their discussions with staff. And that was assisted by the records generated within the website, which contained relevant and reliable information to aim at informed decision-making with the team who were looking after them. The staff who engaged with My Quality reported that those additional insights provided by the families helped them to be more focused, proactive, and to collaborate, and to feel more confident that the needs of the child and family were being recognised. So these combined effects meant that providing individualised, sensitive, responsive support for families in a holistic manner was highlighted. But that said, some teams raised concerns about the potential tsunami of patient issues that might be identified, the challenges of reshaping routes of communication, and the potential for the nature of their workload and their interactions with other teams to be under strain. In practice, I found that the families tended to be highly focused in their choices of priority areas for support and their expectations from the staff. So those concerns weren't observed in practice in this study. However, it's clear that support from management about clarification of roles and responsibilities and appropriate resourcing will be necessary to support resilience of staff as they go through and manage change in this way. But after a year in which so many aspects of our social interactions and healthcare provision have changed so dramatically, harnessing the potential of communications technology to enhance a person-centered approach to care should help to maximise the support that we can give and improve the quality of that support for families. There's more information on the longer presentation, but thank you for listening.
Thank you very much, Nikki, and thank you to all of you. I don't underestimate how tricky it can be to condense a 10 or 15-minute presentation into 3 minutes. I thought they were all excellent, so thank you. Before I jump in with the numerous questions I've got, I'm going to hand over to Lucy so we can get some questions and answers from the audience.
Hi. Okay, so I'd like to start with a fantastic question from Kate Woodthorpe, which I'm going to read out, and it isn't a question particularly to an individual speaker, but more a kind of open to the floor comment question. So please do chip in with your thoughts. So Kate says, I think social media and its potential need to be included in future studies on child and young persons and families' experience. Since my son has been born, Facebook groups have been a godsend, as they have provided access to other people with the rare syndrome internationally and within the UK to people who share similar medical issues, etc. It helps make me feel less alone, and I hope in time it will have similar benefits for my son as the young men in Georgia's study. In terms of information sharing, I do sometimes wonder whether health professionals welcome children, young people and families being able to access so much information, as it means they might be better equipped to question and challenge. Is that the case? So I know we've got quite a few clinicians amongst us. If anyone would like to respond to Kate or share their thoughts, that would be fantastic.
Nikki, do you have any comments on that, given that your work has been around that and obviously your clinical background as well?
Yeah, sorry, I was just hunting for my unmute button. It was interesting. I found that it was a bit of a Marmite question, this stuff about more informed parents bringing their issues to healthcare professionals, and people either loved the idea or were really quite put off the idea, and there was very little in between. I'm still getting to the bottom of why. That seems to apply across the board to nurses and doctors. There were psychologists, and there were a few others involved in my study. The people who were community facing, whether these were community nursing teams or community paediatricians, seemed more willing to accept whatever the families presented to them than people who were based in hospital. But my study wasn't big enough and didn't have enough variety of teams in order for me to categorically say that it's to do with location. But it was a very interesting response that was very, very polarized one way or the other.
Thanks very much, Nikki. Akarna, are you?
Yeah,
okay, thank you.
I think the difference that you found between community teams and hospital teams, do you think that boils down to one difference in time availability, because you do need time to counter especially the sort of false information that you might be coming across, plus also the communication, the skills that I spoke about, how you can sensitively deal with people and respect their opinions and their expertise, whatever the source is.
Some of that may have been time. But I think it's also related to flexibility as well. If you're seeing people in the community or in their own homes, as opposed to within an outpatient session, you have far more flexibility. So I do think there are structural issues about the way people work that have an impact on this.
Thank you, Nikki and Akarna. So I'm going to move on to some questions for Mandy now. So the first one from Katie White wanted clarification whether your study was with children's nurses or did you include healthcare assistants too?
No, for this particular study, it was just registered children's nurses, but certainly this could be extended to include other participants across professions actually, but for this particular study, no, they were all registered children's nurses.
Thanks, Mandy. And can I just ask you a question which has come from Jason and Christy Everest, which is there intention to expand the staff nursing wellbeing studies into home healthcare assistance? And they say these carers walk an even more difficult line as they may work daily with a child for years in the child's home, but are still paid workers, particularly as home care assistants paid through direct payments or CCG funding is the fastest growing sector of employment in the UK.
Yes, it would certainly be interesting to extend the study to that, and in particular for this study, it was interactions that had occurred just within the hospice setting. So certainly extending it out, and that's probably something that I can think about for my postdoc work. Obviously the focus at the moment is getting submission and getting through the Viva. I'm sure lots of people will understand that, but yes, I'm already thinking about what I might do postdoc, so thank you for that.
Thanks, Mandy. And one last question for you from Laura Barrett. Can you please tell us a little bit more about how we might improve emotional intelligence among clinicians who work with children and their families? and also perhaps through health professional education? So it's a big question, but do you have any thoughts that you could share at this stage?
Yeah, I'm editing my discussion chapter at the moment, so there's lots of thoughts around this. Obviously, I'm not a emotional intelligence educator as such. Just briefly, the research that I've looked at about educating people in emotional intelligence says that you shouldn't try to do that per se. You need to focus on the particular constructs of emotional intelligence and educate for those specifically. So things like self-awareness, self-regulation, so concentrated efforts on those particular things. And I think also the new CET framework that's just been launched, that includes from certificate to master's level mention of the relational aspect of children's nursing in palliative care, and certainly using that framework as a vehicle.
Thanks, Man. Thank you very much, Mandy. So we'll move on to some questions for George now. So Stuart Jarvis asks George whether he was able to explore whether social media was used to connect with others with Duchenne muscular dystrophy or with those without life-limiting conditions. And did the users disclose their condition when communicating with those without life-limiting conditions?
Yeah, so just answer the first part of the question. So yes, some were quite keen to engage with others with Duchenne, others less so. Some saw social media as a complete escapism from the condition and were quite keen to show other aspects of self online that they didn't feel that they could portray offline. And so that probably feeds into the second part of the question, which is, so for instance, a good example of this is video gaming. So participants were really keen to often not show their condition to others, and would, you know, sort of develop avatars that were more in line with how they wish to be viewed. So often quite sort of superhero like, and they often spoke about, there's a really sort of powerful quote when one guy spoke about, you know, the ability to be seen as a person and as a gamer rather than someone with Duchenne. And so, you know, invariably there are still real, I suppose, blocks to actually how much these young men can really explore their aspects of self online. You know, there's still discrimination, there's still bullying, there's still all these different negatives that, you know, often reverberate around the offline world that just exist as much online.
Thanks, George. I think it relates closely to a comment that Brian Diems made, which is about, from his experience, that boys with Duchenne muscular dystrophy either engage with their condition online with their peers or they do not. So I think that is sort of saying his experience chimes with what you found in your research, I think, there.
Yeah.
So some questions now, a question for Wahida and for others. So what sort of diversity training is happening in children's hospices and NHS services? And that's from Julia Hackett.
My background is social work, so I came in from a very different angle, and I have to say my research was motivated and driven by practitioners working in children's hospices who were very keen to look at what were barriers to engagement with BME families. The problem was that everyone was looking out there at the barriers being amongst the families, whereas actually the barriers were internal to the organisations. They were systems, processes, practitioners' confidence levels, ability to know how to extract information from families around religion and culture. So there has been very low take-up of training, unfortunately. Speaking to professionals, most of them said they hadn't had any diversity training relating to ethnicity, religion and culture. Very few had, and that had been part of their original training to become a nurse or social worker, which may have been 20 years ago. So it was not updated, which could explain why they were still reinforcing some outdated racial and ethnic stereotypes. So people said that they would value training. It hadn't been offered by the organisation. They hadn't asked for it. However, they felt that was the way to address their challenges in relation to their practice. And can I just go back to this question around emotional intelligence that people were speaking about earlier and how practitioners interact? Something that came up through my research was the process of diagnosis and the language people used, health professionals used around diagnosis. And it was unexpected for my research to focus so much on that area, but parents felt this was a really important topic. And they gave some excellent examples of how this can be done really well and how it can be done really badly. So, you know, it's going back to speaking to parents, finding out what works for them. Language is so important, labels are so important, and diagnosis is often the first stage of coming to terms with your child's condition. So a good experience can lead to a good way of managing that whole process. A bad experience, some parents were still emotionally overwhelmed and in tears 13 years after a bad diagnosis. So emotional intelligence and how we interact with parent carers and families is very important.
Thanks very much, Wahida. That links actually to a question Stuart's asked about Akana and your research, and he asked how relevant is emotional intelligence to your findings as well?
I think it's really really relevant. In particular, we were all trying to unpick, why can't people ask about religion and culture? Why can't they ask about people's religion and cultural needs instead of assuming you have a South Asian name, therefore you must want halal food and you must want South Asian food. It's about being confident in ourselves about our own ethnicity. So if any practitioner who is confident in their own ethnicity, being able to articulate, talk about their religious and spiritual needs, those practitioners were strongest in terms of being able to communicate and assess and speak to diverse groups about their religious and cultural needs. So I had somebody speaking to me about how their child was referred to as a cabbage and that they should have the machine switched off. And that's quite an extreme example, which we don't expect in 21st century. You know, there was somebody else who was talking about how he had just arrived from a country. He had come from abroad as a parent because he was working there. His child was suddenly diagnosed. He had spent 24 hours traveling, and the medical professional didn't wait and hesitate before immediately giving them a barrage of information. So it's about the language that's used, over medicalized, sometimes too much jargon. It can be hurtful language, like the example I gave earlier. And it's also just not taking a breath, you know, before assessing the situation. This parent has just arrived, traveled for 24 hours. They've never met their child before. Maybe we need to give them an opportunity to spend a bit of time with the child, with the extended family. So those were some of the issues that came up. I mean, the data is so rich, so I could go on and on for days. I really could, but I hope
Thank you very much, Wahida. You've really powerfully explained sort of the issues and given us, you know, brought it all to life fantastically there for us. There's a question for Nikki from Andre Bedendo de Souza, and he asks, what are the key barriers going forward to scale up the use of these types of e-technologies in children's palliative care, and how might COVID have helped to address these?
Oh, that's a very big question. What I found from my small study is that in order to use this kind of communication, you need both parties to be engaged with it, both the patient and family end and the healthcare professional end. From the patients and families, of the ones who I have contacted, they have half of them have used it not just for the study, but then continued to use it afterwards. So very extensive use. The other half, circumstances change, and that, I think, changes the form of communication they would like. So I don't think you could view these sorts of technologies as an answer, but part of a menu of potential ways that people could communicate. So I think, and you need to have the flexibility. Furthermore, I'm also very aware that there will have been large numbers of people who may have looked at this and thought, no, that's not for me. And I don't have any way of getting that information from them. So there are some unknowns there. But when it comes to staff, what was surprising was that even though people could see the potential from this, there were quite a lot of barriers that when you started digging about, so why haven't you engaged with this, that actually related to things like personal resilience, adapting to change, how comfortable they felt with a different model of communication. And for some of them, it was that this additional information was coming in, and that was actually threatening some of the sort of personal resilience measures that you put in place that we saw in an earlier presentation, so that people didn't, if you hear from a family and recognize that, you know, there, but for the grace of God, that could be my circumstances, and that's what they're dealing with every day. If that information is coming and offered to you from families, but you didn't seek it, that can actually in some ways be quite threatening. And between the ways that it had an impact on individual professionals and on how teams work together, it is quite a big change that would need implementation and endorsement by management and organisations. So although it's in policy, there is that gap in the middle about implementation that has not yet been remedied. In terms of the bit about COVID, I think COVID did force people to change, and I hope that that will make a difference. But I must admit, most of my recruitment was done pre-COVID and in fact ground to a halt with COVID. So, so I can't really comment on my experience of COVID and how that changed things.
Many thanks, Nikki. So Susie, we've got a question for you, which is, what key lessons can we learn from your experiences with the group if we were looking to set up similar initiatives elsewhere?
That's a fantastic question, thank you. And I could probably talk all day about that, because that was the main motivation for me wanting to share this work, because I thought although there are the specific reviews that we produced, actually it was the fact that it was able to happen collaboratively and so quickly and simply that I think just had so much that was really powerful and potentially transferable. I think probably the things I'd want to highlight are firstly the value of networking. This was all built around personal connections and knowing someone somewhere who had an interest in a topic and being ready to build a bridge. So it was the networking and communication. It was generous attitudes. People were saying, yeah, I'm interested in this, I'll help. Or I've got a friend who's interested, I'm sure they'll help. So that generosity was important. I think I love Anne-Marie's phrase about being an intersectional person. And I love doing that myself. So having a foot in different camps, you know, having a foot in the adult palliative care camp as well as the children's palliative care camp, being ready to build those bridges both personally and organisationally. And then I think the other key thing I'd mention are the vehicles that sort of oiled the wheels. So, you know, Nikki's talked powerfully about using some of these e-vehicles, so have others. So using Zoom, using Google Docs, we can collaborate effectively and efficiently without actually leaving our desks. And then the other part is having a learning and feedback loop. It was so powerful receiving questions from the front line through the COVID Echo, which was just such a fabulous vehicle for this time, but ready to move forwards. It's not just for this time. So we got questions from the front line. We prioritised them amongst our core group. We checked they weren't already being worked on, and then we delivered an answer back to the front line. So the people who wanted to know were getting their answer, you know, face to face, voice to voice, a month or two later. So, you know, there's lots of other things, but I think those would be the main things.
Susie, just to to clarify for any of our delegates that aren't aware, could you just explain the COVID echo?
Yes, so Hospice UK has set up a range of echo meetings for different specialties, and the echo is designed to echo experience and echo expertise. So the model is that you share amongst communities of practice expertise online using Zoom, and these vehicles have been set up over the last few years for different specialties, and particularly for palliative care, actually. So this vehicle was ready to run when COVID arrived. And so Hospice UK set up a separate echo to facilitate sharing of knowledge, information, expertise amongst the hospice and palliative care community live as the pandemic has proceeded. So we started off, I think, meeting weekly and then fortnightly, and now it's monthly. And there are usually over 100 leaders from hospice and palliative care, some children's, mostly adults, meeting on Zoom and feeding in questions, and they have a digest update at the beginning, and then they have a topic presentation, and then they have the chat running all the way through so people can interact live, chucking in questions, and then the team at Hospice UK actually go through that chat between meetings, and then they respond to it the next meeting. So it's a very responsive loop, sharing expertise and current experience across the whole community. Really powerful.
Thank you so much for clarifying that as well. So just
Lucy?
now, George, sorry, Lorna.
Am I right to come and ask a question? Give you a little rest.
Yeah.
I thought there was a really nice comment from Eva in the chat around spending a day with families as part of practice placement can be a good opportunity to educate professionals about emotional intelligence. And I was just very struck by some of the quotes from Archana and Wahida about from their data. And Archana, I'm just interested, was there any positives that came around communication that came out of your work? Because you've highlighted, some really marked and very important negatives, but was there anything positive that we can, learn from and expand upon?
Yes, there were some families who found the glaring difference between the attitudes they encountered in hospices compared to hospitals, and they were very complimentary about hospice care. There were also there was one parent especially who did not have any major negative communication experiences, but all the others had one, at least one, almost all of them had many. They also found, so one of the, I think my main presentation does say this, they found nurses much more compassionate and kinder than doctors. So community hospice teams kinder than hospital teams, and nurses kinder than doctors is what they found generally.
Thanks, Archana. Sorry, Lucy, I'll stop butting in there.
That's fine. We've got a couple of questions for George. Now you've had a chance to have a break, George. So Megan Rigby asks whether you saw any harmful impacts of social media in the population you were looking at. Yeah,
I mean, I wouldn't say there were any direct harms other than what I've sort of touched upon already. The idea that, the sort of discriminatory behaviour, the bullying that often exists offline does also exist online, and participants are really sort of keen to and aware of trying to avoid that. I think there's a larger harm which a lot of participants spoke about, which was this notion of almost becoming trapped within video gaming. So you have this wonderful world that provides all the things that offline doesn't, and so to come out of that can have to be quite challenging, particularly when there was a perception that there were few opportunities to do things offline, and particularly things they can do online. So they spoke about this notion of a vicious circle and getting yourself trapped in this world that is then really quite hard to come out of. I'm not sure how much of that's a harm from the participant, or actually that's a much bigger issue about actually, there's so much research out there on transitions for young men with DMD, and actually how poor it still is. particularly after mandatory education. Touching on, COVID, this notion of isolation. Yeah. Well, my experience would be the majority of the young men I spoke to were already isolated before COVID.
Yeah.
So, yeah.
And sort of linked to that is a question from Julia Hackett, which is, what do you think the increased role of social media and experience of isolation for many during COVID may mean for the group of young adults your research was about?
Yeah, and this is, I don't know if there would have been any marked change. Obviously, the interviews I did were before COVID, so I don't know how the young men I interviewed experienced COVID. But as I say, the sort of the idea of, of isolation, of limited social contact offline existed in their lives before COVID came about. I think the only positive really is that, hopefully we've started to get some sort of anchor, some sort of understanding of actually how beneficial social media can be as a source of connecting people who are often isolated. And maybe COVID's, brought that to the fore more.
Thanks, George. We've got a comment from Linda Sanderson, which I think relates to perhaps Wahida's talk mainly. And she said that certainly in nurse education, very little time is given to exploring our own culture, our own background and our own values. And I believe this would help to develop confidence to talk to others about their culture, values, etc.
I do agree with what Linda's saying, because I did some training with some nurses a couple of years ago, and they were frustrated by the fact that when they do sometimes try to access this information from patients, they weren't forthcoming with all the information that they needed immediately. So the exercise I started with was saying, could you tell me what your religious and cultural preferences are around death and dying? And there was like complete silence. People were like, oh, hold on. Well, I'm going to have to think about this. Well, I don't know if I want to talk about this. And is this the right time and place? And I was saying, well, can you see now what some of the challenges are when you're asking patients and their parent carers? It's not as an easy question to ask. And it's not an easy question to answer. So there are definitely challenges around that. I would just like to say, we talked about diagnosis and medical professionals and the language they use, which can, and the way it's done is sometimes criticized, but there were also in my research some extremely positive examples. People spoke about ensuring that medical professionals ensured that an interpreter was there, even though family members could have provided the interpreting, but they ensured a professional interpreter was there. There was a nurse there to support the individual. They were given written information as well as verbal information. An appointment was made soon afterwards to follow up and check if they'd understood the information. So there were lots of examples of what practitioners can do and should continue to do, but there are also criticisms, which are things that we need to be aware of.
Yeah, things to learn from, and yeah. Thanks very much, Wahida. I think we've finished our session pretty much on time. Is that right, Lorna?
It is. Thank you very much, everybody. It was a really insightful session. Lots of excellent presentations and some good questions. You've all now got an hour to take a bit of a longer walk and have something to eat. And do encourage you to come back sharp for 1:30 when we have our next plenary session, which is our experts by experience in the role of parents and young adults in research, which I am very excited about. So thank you all again, and hopefully I'll see you all in an hour.